Okay, so I gather everybody that's joined us should now be in the room, and we are going to go ahead and get started. Thank you everybody for joining us for the latest Duke media briefing on the COVID-19 pandemic and its effects on society. I'm Greg Phillips with Duke Communications. I'm here to moderate. We have three Duke scholars with us today, all three professors of medicine, to discuss the issues involved in testing for COVID-19 and what role testing should play in reopening society. I'll introduce them in turn to get the discussion going, and then we'll open it up to questions. We are recording this briefing, and we'll make that recording available afterward upon request. So with us this morning, we have Chris Woods, who is co-director of the Hubert-Yeargan Center for Global Health at Duke and chief of the Infectious Diseases Division at the Durham VA Medical Center. Good morning. We've got, thank you. We've got Thomas Denny, who is chief operating officer of the Duke Human Vaccine Institute. Good morning to you. Good
morning.
And Michael D. Gunn is a professor in immunology at Duke University School of Medicine. Good morning.
Morning, Greg.
So, Dr. Gunn, I'd like to start with you. Can you explain the difference between genetic testing and antibody testing and the relative strengths of each of these kind of things?
Yeah, so there are basically two types of tests. One test tests for the virus, and what that tells you is whether or not you have active infection, and theoretically whether you can transmit it to other people. The other type of test tests for antibodies against the virus. And what this tells you is this gives us an indication if you have ever been infected. It doesn't necessarily indicate whether or not you are currently infected. And if both of those tests work as they're supposed to, you can get a pretty good idea of where someone stands at any time during the course of infection. Currently, we're early in this, and so we don't know exactly how to interpret all of these tests. The tests for the virus, which is a measure of, which is the genetic test, we've seen a lot of cases where those stay positive for a long time. And we're still trying to figure out exactly what that means. The thing about the antibody test is it may take a while to turn positive. It takes a while for you to develop antibodies after you have been infected. And the other thing to remember about this test is just because you have antibodies, that is not a guarantee that you are actually immune to the virus, because not all antibodies will block viral infection. Go
ahead.
I was going to say the current problem with both tests is they are, in their current form, they are almost exclusively laboratory based. Moving forward, I think our hope is that we can take tests out to the point of care to allow much more widespread and easier testing.
Gotcha, thank you. Dr. Denny, I'd like to move on to you. Yeah, with different kinds of tests in use and so many different tests kind of flooding the market right now and in development, how do we know they're all measuring the same thing, and how much of an issue are validation and standardization?
So thanks, Ivan. So the short answer is we don't know that they're all measuring the same thing, and this is one of our big challenges ahead of us. So when you typically develop assays, you want to go through a fairly significant validation and standardization process. And with this pandemic, we're racing. We're in a war, and we're racing to get all the tools ready faster than we would typically do this for a lot of other uses. So what you want to be able to do is have a number of different testing platforms and be able to have a well-curated set of samples that you can run those samples on all of the platforms and look at your results and then start to understand, are they all picking out the same measurement, or are they measuring different types of antibodies or different types of responses? And this is critically important to what we're trying to do when we say we're going to test everyone and understand who has protective immunity or who doesn't have protective immunity, who's for all the dynamics around that type of those types of measurements.
Gotcha, thank you. So, Dr. Woods, Dr. Denny was talking about this race that we're in. How far, can we say how far we are from an effective test and trace approach? And can we reopen society without reliable information about how prevalent the virus is?
Yeah, appreciate the question. Thanks for allowing me to be here this morning. first of all, I would start by saying we're all due a measure of congratulations so far with this approach to social distancing. We've taken both the public as well as our community leadership has done a great job with that, and I think we are seeing that flattening of the curve that you hear so much about, which reduces the pressure on our health systems, and at least in particular here in North Carolina, but actually across all of the states, this appears to be having success. Now there are deviations from that at certain county and levels and within certain populations. But what this harkens to is an expected transition from the mitigation approach that we've been in, where we're reliant on our social distancing, back to a containment approach. And the containment approach really relies upon testing, contact tracing, and then the isolation that takes place. The problem when the outbreak or the virus initially entered here in the U.S., those tests were not widely available and still are not quite where we would like them to be. But we do require, as Dr. Gunn alluded to, we need those tests to detect the presence of virus in order to perform our that test contact tracing and isolation approach as we again make that transition back to containment. We need to have tests that we understand their performance characteristics, and this is exactly what Dr. Denny was alluding to. And ideally, we have those results quickly, and that means we can be more precise in how we put in place our public health interventions. The other component to that, of course, is understanding what the background rate of immunity is, and this is what's there are a number of studies that will be performed by our public health bodies. In fact, here in North Carolina, there are a number of studies that are already being supported or will be supported as we move forward that will look at the prevalence of disease and the prevalence of at least antibodies in certain populations to give us a sense of where we stand with regard to a herd immunity. At this point, we've done such a good job with the social distancing. The expectation is that the rate of immunity will actually be quite low, which means we would expect there to be, over the course of the next several months, periodic outbreaks of disease. But now we hope to have the diagnostic tools and the public health tools to again contain those outbreaks as they occur.
Gotcha. Thank you very much for that. Okay, so we've got a lot to dig into here, and I certainly have questions, but I'd like to open it up to everybody else on the call for questions. If you are on Zoom, you can use the raise your hand feature, and we can unmute you to ask a question, or you can actually type a question in the Q&A window if you prefer. If you're calling in by phone, you can raise your hand by pressing *9, and then we can unmute you to ask a question that way. So right now I'm going to take a moment to let people raise their hands so we can unmute them and take a question or two. And if we get a couple of moments without any, then I will ask a question of my own. But I'll just give people a moment here. Oh, we have a question in the Q&A. Okay, and I'll let you guys decide which one of you wants to tackle this first. What level of testing do you believe is necessary to reopen the economy fully? As in, what number of tests per week?
So, I mean, so several groups have estimated that. And it's dependent on your strategy, I guess, is the way to do it. I mean, people envision that, oh, we have to test every single person on a weekly basis. And that's not true. I mean, this is kind of like same thing that happens in a forest fire. Once you get the fire under control, then it's an issue of, managing the hot spots. And what we need to do very efficiently is, be able to identify people that are at risk for having been infected, that have been in contact with someone who either developed symptoms or had a positive test, and then rapidly be able to test those people to cut down on the spread very quickly. I mean, this is a fast-moving virus, so this may require a technological solution, such as I'm sure you've been hearing about the apps that will monitor who you've been close to. But if, with a very robust tracking system, it reduces the number of tests that are required. But I can't turn that into exact numbers. Maybe somebody else can.
I would add to what Dr. Gunn just said and focus on, my view is focus on early on first responders and healthcare workers who have been involved in taking care of the patients in this current round, and see if they show any evidence of antibodies which may suggest that they are protected. In other words, try to be prepared as if we do see another surge, that hopefully we have those that have to take care of the patients and are the first responders that will have a better understanding of what risk those individuals have.
I'll go ahead and add my comments. I agree fully with both Drs. Gunn and Denny. I would mention that as with our understanding of the performance of the test, our understanding of we're still learning. And so these studies or these investigations that are being put in place where we understand the change in prevalence in a community over time will help inform just those types of questions. We hope to be generating those data quickly. Of course, we need good testing technologies to be able to do that. And again, once this will allow us also at the same time to assess those augmented contact tracing technologies that Dr. Gunn alluded to, and see how well they are actually taken into the community, what the issues are with privacy, what our ability is to really get to those first and second generation of contacts to successfully control those forest fires as they break out.
Gotcha. Well, thank you, Dan. I hope that answered your question. We're now going to go to a question from Mary Ellen. And speakers, if you would, since we have some people just joining by audio, if you could identify yourselves when you start to speak, panelists, that would be great. So Mary Ellen, I gather you have a question.
Yeah, hi, I'm Mary Ellen McIntyre with CQ Roll Call in DC. I was hoping you guys could talk a little bit about what you think sort of the relationship between a national testing strategy versus state-led efforts should look like, and sort of what that kind of partnership should be like.
Maybe I'll lead off and the others can comment. It will be location and dependent. I think that we require substantial national leadership from our national public health entities, and but ultimately at the state level, that's where the data will be available to make the best decisions about where to invest current resources and where to direct subsequent resources. In a state like North Carolina, actually, we are fairly democratized, and even the decision-making capacity is heavily focused at the county level, and so so there will be, and appropriately so, there needs to be involvement at all levels, local, state, and federal, with a good dose of those of us doing research at the academic level, contributing our expertise.
Thank you, Dr. Woods. Dr. Gunn or Dr. Denny, would either of you like to add to that?
Yeah, I'd go along with what Dr. Woods has said, that there needs to be a strong national component of support. This is going to be costly. It's going to take a lot of people to execute these plans, but I do believe at the end of the day, the testing part of it has to be very local, and you're going to have to triage into this, grow into this, and I think you go in each local community and you work with your public health teams, and you try to identify those within that local community setting who are the most at risk early on, and then work out in rings, if you will. You know, we talk about rings of containment at times and things like that. Well, this is a, you know, the same concept for me, is start where those are the most risk, potentially lower socioeconomic groups that are typically see more health problems, and then work away to the lower risk individuals, because all this is going to take time. You can't get it done overnight.
And I say
Thank you, Sorry, that was Dr. Denny. Thank you. And Dr. Gunn, you've got something to add too.
I say the one thing that national coordination would really be helpful on is the development and validation of tests. It's been kind of a free-for-all up till now with, you know, every company that could conceivably put out a test has put out a test. And there hasn't really been the quality control that this needs. And the two things that would really be helpful as far as national coordination is, number one, you know, coordinated development of different types of tests, and number two, validation. And that doesn't have to be done at the national level, but I think it would be helpful if it were coordinated at the national level.
Gotcha. Thank you very much. Okay, we've got some more questions in the chat here. And here's one from Jacqueline Stenson. And the question is, what are the main hurdles we need to overcome to have enough coronavirus tests? Which, that's a big one, I realize, but anybody want to offer up what the biggest obstacles are, or one of them at least?
You know, the first part is just supply chain. So just to pick up with what Dr. Gunn had previously talked about, standardizing and validating internationally in the HIV world, the WHO does something like this for a lot of diagnostics that are used around the world for HIV. So they do what they call a pre-qualification. And part of the pre-qualification process is that you are working with a vendor that you're sure has a good manufacturing record, and they're able to have a sustainable supply chain. So it would not help us to spend time on validating an assay that is a company that does not have the ability to have a consistent supply chain and manufacture their products and make them available for testing. So at a national level, one could sort of pre-qualify a number of entities, and you want to keep this in a free market, and you want to have competition, but you also want to have it focused where you know you're going to be working with teams that are there for the long haul, that have good quality manufacturing processes, and will be able to sustain that testing kit platform for for a sizable period going forward.
Yeah, this is Chris Woods. I would just add to that the supply chain point to mention that beyond just the test kits and the reagents that are required for those, the supply chain for the materials needed to acquire the sample that we will ultimately be testing, the supply chain of the individuals who the workforce are needed to actually collect those samples, and being creative about means for self-collection when appropriate and when can be performed safely, are also a strong consideration. Just the supply chain has a broader context.
And so this is Dr. Gunn. The one thing I would add to this, there have been several reports come out, and one thing that people have looked for is kind of a way that we do this testing. The current polymerase chain reaction based test, I mean, it's a complicated test. It requires enzymes and chemicals and a lot of steps, and there are some machines that can automate it, but it's still just not an instant test. I mean, you could, in theory, have tests that instead of detecting, the virus RNA, detect some viral proteins immunologically. And in theory, if you can develop those tests that are sensitive enough, they are very rapid and easy. I mean, a pregnancy test is an example of that type of test. And those can be produced on a very large scale. The trick is to get them to a technical grade where they have the sensitivity we need in some form.
Gotcha. Okay, thank you very much. We're going to move. We've got several more questions here in the Q&A, so I'm going to move to one of them here. Got a question from CBS 17. It says, North Carolina is currently testing 2,500 people per day. At that rate, it would take roughly 11 years to test every resident of North Carolina. What level of testing do you feel is needed to be considered adequate?
Okay, where's one of our public health people to?
Yeah,
Chris, this is probably you. You're the best here.
So this is Chris Woods. Again, we've shied away from assigning a number to this, and I think that that's appropriate as we get, a number of focused investigations are going to be supported by the state, and we will have a better understanding again of what the background immunity will be, et cetera. We've talked a little bit about focusing testing efforts on those populations that are at greatest. We need to consider how much we focus at trying to identify those who may be asymptomatic carriers of the virus, and that would augment those ultimate numbers. There's no question that more testing needs to be performed. I actually think we're probably underutilizing testing capacity that exists in the state at the moment, and we can increase those numbers significantly. However, we need to be developing strategies with between the health systems in the state, as well as with the public health infrastructure that allows us to be most efficient about testing. But again, I think we can accommodate a greater number of tests.
So this is Dr. Gunn. The one thing I would add to that, I mean, the reason we can't give you a straightforward answer, it kind of depends on the situation. I mean, clearly this is not going to be an all or none. Suddenly one day, okay, we are eliminating social distancing, everybody go do whatever they want. This is going to be a staged rollout with different populations. And one of the things that will determine how many tests we need is what is the level of infection at the time we eliminate social distancing. I mean, if there's still a lot of infections going around, it's going to be hard. We're going to need a lot of infections are going to pop up. We're going to need a lot of tests. If we can really damp down our ongoing level of infection to a very low level, it's a lot easier to track the hot spots that pop up and jump on them. But if you're not doing that, it becomes a game of, if you don't get that baseline down, it becomes a game of whack-a-mole.
Yep, I agree.
Very well said.
Yep.
Gotcha. Thank you, gentlemen. We've got some more questions in the Q&A that I'll go to. I'll just remind the reporters on the call that you can raise your hand if you actually want to ask a question vocally, and if you're calling in by phone, you can do that by hitting *9. But for now, I'm going to return to the Q&A panel here and find us another question. Hold on a minute. Sorry, I've lost myself here for a moment. Okay, here we are. So, okay, we have a question here in the Q&A that says, what is the problem with antibody testing? Technically speaking, is it how the antibodies are formed or how they interact with the technology, or is it a lack of chemicals such as reagents? So can anybody kind of talk about problems with antibody testing?
Well, I'll start. How you make the antibody test can be variable depending upon, so in other words, what you're trying to measure in the individual. So of this virus, there's an envelope, there's a spike protein, there's different core components we call of the virus. So depending upon what you're measuring, that could be variable from different kits, kit 1 or kit 2 or kit 3. And then once you decide to make a reagent to go after that measurement, how well you make it, think of sensitivity and specificity type of issues. So how well the antibody goes after the target you're looking for. If it can really fit like a nice lock and key relationship, then you probably have a good set of reagents. If it does not fit like a nice lock and key relationship, then you don't have a nice set of reagents, and you may have less specificity and less sensitivity, and then that translates to not measuring everything you'd like to measure, or missing some signals.
I can add my thoughts. I'm sure Dr. Gunn has some thoughts on the immunological aspects, but one of the considerations, again, is, as we alluded to earlier, is that when you're developing these assays, is taking into consideration the temporal dynamics of the infection and the time course with which the antibody response is being manifested. Other considerations are diversity of strains of this particular virus that are emerging as the virus changes over time, as it moves through populations, and making sure that there are consistencies on both the detection tests as well as on the serological assays, that they maintain performance. And I guess that's sufficient to mention.
Gotcha. Thank you very much. We're going to move on to another question here from the Q&A. And okay, we've got a couple of questions. Well, here's one pertaining to universities. A national testing strategy by a group at Harvard published yesterday says that university laboratories can be repurposed to run high volumes of COVID tests. Hang on. And another question has just come in that's pushed that one out of the way. Hold on, look. So, okay. A national testing strategy by a group at Harvard published yesterday says that university laboratories can be repurposed to run high volumes of COVID tests to meet demand. What's your view on this? Can universities be a major source of testing capacity in the US?
Yeah, I think they can. Having said that, what one has to understand is there is all different levels of doing a test. So, you know, at one point in my career, we did tests as what we would call a research test, and we did it with not a lot of standardization. And then you can, introduce standardization such as what's called GCLP, good laboratory principles, or good clinical laboratory principles, or you can be in a laboratory that has an accreditation for testing. So while I don't think every lab has to have the highest accreditation to help do this public health type of testing, I do think that laboratories have to meet some level of standardization and criteria. Otherwise, I think what you will find is a lot of variability in the testing that's done from site to site. So I would not be in favor of just saying every laboratory that can do an antibody test start doing testing for public health purposes here and surveillance testing. I think there should be some set of mobilization and standardization across those labs, and making sure that you have the appropriately trained people that are familiar with the assays or these type of assays, and that you have then some sort of quality control measures that are put in place that you can say, well, if 3 laboratories are doing 1,000 tests, are they all doing at the same level of performance? Otherwise, you end up with a lot of data that could lead us down a direction with a lot of confusion.
Thank you, Dr. Denny. Either of the other panelists got anything to add there?
Not really.
Okay. Well, we'll move on to another question. And this is more for focus on people who are at home dealing with this thing. Is taking temperatures a good way to test for indication of the virus?
Go ahead.
Go ahead.
Well, it is good. It is not, I'm not exactly sure what percentage of, well, we don't know what percentage of people actually become symptomatic and develop fever. It's a good screening. It is not absolute because as far as we can tell, there are a lot of people that are infected, don't develop a fever, don't develop symptoms. Not perfect, but it's better than nothing.
Yeah, what I would say, in full agreement with Dr. Gunn, this is Chris Woods. I think in the hospital setting, we do see a fairly consistent presentation, not totally homogeneous, but fever and shortness of breath are fairly common in that group. When you move to the outpatient setting, which is where we need to be implementing these strategies, the diversity of symptoms I have found is tremendous. I even have said on occasion that if you've seen one case of COVID-19, you've seen one case of COVID-19. The variety is actually quite surprising, I find, and it makes the public health approaches and the targeting that we've been talking about really difficult because of the substantial number who are asymptomatic or the substantial number who may just feel fatigue and all over body aches. You know, we have these interesting group of individuals presenting with anosmia or the loss of smell or taste in a small percentage of individuals. And so it's quite varied.
Gotcha. Okay, thank you both for that. Okay, now we have another question. There are a lot of calls right now to reopen the economy. Are we at the point where that even makes sense medically? And if not, what are the risks of reopening right now?
So this is Dr. Gunn. I mean, you have to understand the people from our perspective, you know, the people that are advocating that we eliminate social distancing right now and that we just completely open up the economy. I mean, what they're really advocating for is that every single person in this country become infected with coronavirus, because that's what's going to happen if we throw things wide open. You know, so if you like your grandmother, you may not want to do that.
Short and to the point. Dr. Denny or Dr. Woods, do you have anything to add to that?
Yeah, I am concerned that this rush to forget everything we've been through the last 6 weeks or 8 weeks is getting momentum that I think is a bit premature. I think if you think of rings of containment, you can think of rings of loosening the containment. So you can start small and then you watch and be ready to do contact tracing and testing in that area, and you build on it. So I'm concerned that we're going to find ourselves potentially in a worse shape than we have been through the last 6 weeks if we go too fast at this. And the other part, I'm sympathetic to people. The other part I would say to what Dr. Gunn mentioned is, I know there are a lot of people that have lost jobs and suffering incomes right now, loss of income, and they may be motivated to by those concerns, and I understand that, but that's something that we can deal with on a national level, as opposed to forgetting all the efforts we've been through for the last 6 to 8 weeks, and take this a little bit slower.
Gotcha. Sorry, go ahead, Dr. Gunn.
Well, I would add one thing to that with respect to people's frustrations. And like Dr. Denny, I completely understand people's frustrations, but I think one of the reasons they're frustrated is no one has given them a clear picture of how things are going to advance. No one has shown them the light at the end of the tunnel. And so I think one of the things that would be very beneficial if we could do it at the federal level. It's like, listen, this is what the path looks like going forward. Here's the schedule. Here's the schedule we're on. Here's where you are in that line, and give people, an expectation to work with and clearly explain the benefits of that. I mean, if we just leave it as it is now, which is the story kind of changes every day, I mean, no wonder everybody is frustrated.
Yeah.
Well, that being the case, that kind of leads to the second part of that question, as to where we are, on this timetable. How far are we from, as you've already said, it's not going to be a magical reopening and everything goes back to normal. But how far do you think we are from taking the steps to gradually reopen everything that's been closed? Or what do we need to know in order to do that, take that step?
Well, as we've talked about, we do need a clear message, but there are messages that are coming out and being proposed in this regard. Most suggest a phased approach where you are letting back into the, I'll use the term economy, or people going back to work, percentages of folks with regard to how essential their role is considered to be, and working towards a full opening by the fall, with maybe some phased institutional opening in schools and those types of things. And I think there's a lot of compelling rationale for that, for the reasons that both Drs. Denny and Gunn have mentioned, that you don't want to do things all at once. But I think we do realize there needs to be some progress in that regard, and I suspect that most of us agree that that will be taking place over the next 6 months, as most of the plans allude to. We will, as we've emphasized, continue to have the need to do this containment, circles of containment, identification of where the cases are occurring. We may have to have statewide stay-at-home orders again imposed if there is a new surge of cases in certain locations. Hopefully we won't need to do that on the national level once we work our way through this. But we do need clear guidance, and that needs to come from, as we've all stated, at the federal level, and it needs to be supported and slightly modified at the state and local level.
Okay, thank you, Dr. Woods. Oh, sorry, did you have something to add?
One other part to that, what I think of it is, we've spent about 6 weeks going up the curve, and I think we have to spend a lot of weeks going down the curve, and we watch that curve continues to decrease, and then use that as a guide for helping to reopen or gradually transition. But to start to do it too soon, when most places we've just barely plateaued, and it took many weeks to get up to that point. So you still have to go down the backside of that curve before your numbers are lower.
Gotcha. Thank you, Dr. Denny. So we've had a number of questions in the Q&A pertaining to plasma. And so to characterize one of those questions, can you discuss the study that used plasma from recovered patients and how that could potentially benefit current and future patients?
I'll quickly mention what we've been doing so far at our institution, and a couple of the things that are happening nationally. Doctors Gunn and Denny can talk about the specifics of how you identify the best individuals for those donations. But because we have had substantial, this type of therapy, convalescent plasma or serum therapy is a very old approach to treatment, and there are some risks associated with it, but they can be reduced. We've had some success in treating other viral diseases, including Ebola, with this approach. It has been discussed by a large consortium of individuals across the country. There are a number of studies that have been put in place, including an emergency access to plasma protocol, as well as a number of smaller randomized studies that are important to have in place so we can assess the performance of this type of treatment versus other potential treatments. Always best to do these in a controlled clinical trial context if we can. Through the emergency access protocol, where we've identified potential donors, we have allowed for the identification of donors here locally, and have actually provided plasma already to a number of individuals at our institution.
Thank you, Dr. Woods. That was a pretty comprehensive answer, but do either of you have anything to add to that?
I would just say that with what Dr. Woods has mentioned about testing, so when you develop that process, you want to make sure the person is not showing any viremia. So you want to test to make sure that they are free of actively replicating virus. And then we are testing to see if they have an antibody present. But what you'd really love to do is test to see if they had a functional antibody. And by that, what we refer to a lot of times is an antibody that is a neutralizing antibody. And those assays are pretty labor intensive, and it takes a while to get them up to the point that you could support wide scale use of them in a real time to make those decisions. But hopefully we will learn as we do these tests on donors that provide plasma, we may learn that some are actually better donors for that type of therapy than others, and it may be related to the type of antibody profile that they have.
Gotcha. Thank you, Dr. Denny. That actually leads us into another question that we had in the Q&A, which says that many people who have been deemed to have recovered from COVID-19 say they were never retested for the virus. Do we need to be retesting COVID patients before releasing them from medical facilities or self-quarantine?
I think this is a Dr. Woods question.
Yeah, I was just going to say, my wife walked in. Could you repeat that question?
Sure, absolutely. Basically, the question was that there are some patients who have recovered from COVID-19 but haven't been retested. And the question was, should we be retesting people who have recovered from the virus before they're released from self-quarantine or from medical facilities?
Yeah, I mean, in the ideal circumstance, you would retest them. There are a couple of issues with that. As we've mentioned before, the availability of tests, it's been a fairly limited resource. I think that's changing. As I mentioned earlier, I think we do have more tests available now and could consider that type of an approach, particularly in people returning to work in high-risk situations. One of the issues, though, is we don't really understand the dynamics of shedding as people are recovering from illness. We know that in certain individuals, we can detect virus from the nasopharyngeal cavity or from the throat, and even from stool in certain situations for a prolonged period of time, meaning several weeks. What risk that shedding poses to others around those individuals is not well understood. The epidemiology that exists would suggest that risk is fairly low, but we are still learning a lot about this virus and how it is transmitted. And so there is rationale to do that testing if we are able to, but we need to make sure we understand what the results of that testing may mean with regard to the potential for it to be transmitted.
Gotcha. Thank you very much, Dr. Woods. I'm going to go back to the Q&A here so we can get through as many of these questions as possible. We have a question that says, we've heard a lot about the San Mateo testing study. Can anyone talk about the limitations of those results? Apparently, the conclusion was that the rate of infection versus the rate of hospitalization or death means that COVID is not as virulent or as dangerous as first thought. Is anybody familiar with that study or can address those results?
Yeah. I believe that's the Santa Clara result. Is that correct? The Santa Clara County. Yeah. I think we've understood this for a long time, that the rate of detected disease does represent a tip of the iceberg effect, and that there is some number of individuals for every hospitalized case and for every death that occurs that's been estimated at 50 to 1 or even higher. I think that's where some additional studies along the lines of the San Mateo study need to be pursued. And again, they need to be location specific. And these are the types of prevalence studies I alluded to earlier. Whether or not there is change in the virus itself that maybe make it more transmissible or cause less severe infections over time or more severe infections over time is something that we need to continue to monitor. I'm sure others will have comment on this as well.
Thank you, Dr. Woods. Either of you want to chime in on that?
I agree with what Chris
pretty good summary.
Gotcha. Okay, fantastic. Well, I'm going to try and get through another couple of questions here if we have time. Can you talk about the issue of strict states and counties versus loose states and counties? For example, South Carolina versus North Carolina. The issue of these, strict counties versus loose counties being proximate to one another, and what kind of issues that raises.
It raises a lot of issues. The best analogy I heard is, well, let's just have one end of the pool that the kids are allowed to pee in. It doesn't do that much good if there's places that aren't being restricted. People drive across the state line, and the lovely and charming folks from South Carolina will come up and infect us, no matter, even if we are doing good social distancing. So yeah, it is a problem.
And I think the best approach that, the so-called regional, where you have a group of states, and, as a former Northerner, but following the New York and Connecticut and Pennsylvania, New Jersey sort of alliance and trying to work in a region there. I think that makes sense. If we could get regions to cooperate and work on plans that are consistent with each other, that would help us go a long way in this direction.
Gotcha. Thank you both very much there. We've got one more question here in the chat. Would widespread antibody testing be enough to reopen the economy? I know that's kind of broad, but can we have any comment on that?
No.
No.
It would help. But the situation, if it takes 10 days to develop antibodies after you're infected, that means, I can be infected other people. I get an antibody test, and that antibody test comes back negative. Like I said, the testing for the antibodies tells us something very different than testing for the virus itself.
Yeah, I think what we have to look at this as is we have a toolbox, and we need a number of tools in that toolbox, and we need to use them as a team to address this. So antibody testing is one part of it, and there's a lot of other phases of public health issues or other types of testing. So we talk about the virus, the PCR test. So it's a combination of approaches that need to be in the toolbox and need to be used within small regions as we work to open up the economy.
Gotcha. Thank you all very much. Okay, we're going to do one last question and then we'll wrap this up. And I'd like each of you to take a stab at this one. What's the one most important step that you'd like to see the federal government take right now? Because obviously the response has been somewhat scattershot, one might say, but what's the one thing that you'd like to see the federal government do before anything else, if you can boil it down to one?
For me, the political leadership has to be consistent on a day-to-day basis. And I believe they have to take their lead from the public health experts that are there to provide the best scientific information and data on where we are in this pandemic. And then to provide clear leadership on a day-to-day basis, not on 1 hour, one position, and 3 hours later. That confuses the public. The public has a short retention span on a lot of these issues, and there has to be. And then for implementing all these areas that we talk about, there needs to be a funding stream for that. It's costly. And that is one area that the federal government can help, I think, in getting the fund flow into states, into local areas to help operationalize a lot of these different areas.
Thank you, Dr. Denny. Dr. Gunn or Dr. Woods?
So I would say the thing that the federal government could best do right now is come up with a plan. The American people are very willing to sacrifice for the common good, but we need a coherent plan that everybody can follow. I mean, lots of people have put forth plans, very good academic centers, think tanks. There's a couple of ways to do this, but someone needs to say, okay, here's the plan. We've taken the best advice. We're going to move forward with this. And we are asking you as individual citizens to buy into this plan, because that's how we're going to actually get control of this pandemic.
Thank you, Dr. Gunn. Dr. Woods?
Yeah, mine's kind of a blend of the two, and that would be to empower the entity that really has the responsibility for this type of response, and that's the Centers for Disease Control and Prevention, which unfortunately has been far too quiet. They're working very hard in the background, but I think they're the ones who need to be providing this leadership. It's been diverted to other entities to some degree. And I think when it ultimately comes time to implement these types of plans, it would be the CDC doing that through the extension of the Council of State and Territorial Epidemiologists involved with all of the states, as well as the local health departments as well. So really leveraging and empowering those groups and making sure they have access to the tools in that toolbox we were alluding to earlier.
Gotcha. Thank you, Dr. Woods. We're going to wrap it up there. So thank you ever so much to our panelists, Dr. Gunn, Dr. Denny, Dr. Woods. Thank you for everybody for joining us and for all your questions. Everybody who registered for the briefing will get a copy of the recording, and that should be headed your way shortly. So thank you, everybody, for joining us, and please stay well. Thank you.
Thanks so much. Bye.
Thank you.
Thank you.